Gastrointestinal and urologic emergencies. If you've ever had abdominal pain, you know that it can be a life changer. You can be rocking along having a great day and suddenly have abdominal cramps, nausea, and vomiting, diarrhea come on, and it is a life changer. It does not matter what you're doing. You will pretty much shut down and let your body do what it needs to do. So not pleasurable. And take your normal GI virus with the signs and symptoms that I just mentioned, and take that to an acute. You're thinking, yeah, my abdominal pain was acute. If it's appendicitis, or peritonitis, inflammation of the lining of the abdominal cavity is peritonitis. It becomes even more intense, and shuffle in with that a life-threatening problem, and we have to be able to recognize life-threatening problem, deal with it. For the most part, we can have an idea of what's going on with our patients with acute abdominal pain, but it's difficult to determine exactly with the tools that we have in our patient's living room, on their office floor, or in the back of our ambulance. Something like appendicitis is more easily determined pre-hospitally. For us, treatment doesn't change. Treatment is mostly supportive unless your patient is exhibiting signs or symptoms of shock, or if your patient is, well, that's a couple of different kinds of shock we could be dealing with here. Our patients could be presenting with septic shock secondary to an infectious process in their abdomen. What would be the signs and symptoms that would point us that direction? If you have a patient with abdominal pain, they're hypotensive, and they have fever, then we need to be thinking in the direction of septic shock, or if we have a patient who is presenting with cool, pale skin, cool extremities, tachycardic, diaphoretic, and having abdominal pain, and they have a rigid abdomen, then there's a good chance that we have a patient in hypovolemic shock. In both of those cases, we need to manage the airway, manage the ventilations, get the patient supine in the shock position, and contact ALS if ALS has a relatively short response time to your location, or they can you can meet up with them on the way to the hospital. Abdominal pain, many of these things as with abdominal pain issues are surgical issues, not something that we can fix pre-hospitally. In the case of a patient with septic shock, they could have a surgical and medical issue. The medical issue would be antibiotics to treat the septic shock, and then possibly surgical intervention to deal with the underlying cause of peritonitis, which eventually led to septic shock. Okay, we'll talk about the contents of the abdomen today, as well as a couple of retroperitoneal organs. What in the world is that? The peritoneal cavity, the abdominal cavity, is lined with parietal peritoneum, and then the organs, the surface of the organs has visceral peritoneum on them. So when we talk about the parietal cavity, the abdominal cavity, that's everything within the peritoneum. The kidneys are retroperitoneal, so they are not inside that peritoneal abdominal cavity. We're going to talk about those in the same portion of the lecture today, but they are in quite a different location, even though they're in the general vicinity. And then we'll talk briefly about the genital system, and then we'll wrap it up with the urinary system. And the big thing will be, two things we'll be talking about there would be urinary tract infections, and then renal calculi or kidney stones. Never had one, don't want one. Extremely painful, according to my patients and my friends. I have a female family member who has had babies, and she's also had kidney stones, and she said the kidney stones were worse than having a baby. So I don't know. Thank goodness I've never done either. All right, let's talk about solid organs, or list what they are. Liver, spleen, pancreas, kidneys, ovaries. Injuries to those solid organs obviously can cause significant bleeding, which can lead to hypovolemic shock. Hollow organs, gallbladder, stomach, small intestine, large intestine, and then the urinary bladder. What happens when we have a perforation in one of those and the contents of that hollow organ are spilled into the abdominal cavity? Our patient is likely to develop peritonitis, inflammation of the peritoneum, and then eventually develop septic shock. So, all right. And if you like pictures, that's straight from your book. That's kind of what all that stuff looks like. When you see a patient's abdominal cavity open, things aren't all separate and spread out and easy to see and easy to label. When everything is packed in there, it stays in pretty much the same location from patient to patient, but it's stacked in there, and so it's not as distinct and separate as this looks. That's why you hear surgeons say retractor. They have to pull things, have somebody help pull things out of the way so they can get down to the structure that they need to repair or remove. All right, we've talked about this before. When does digestion begin? It begins when you chew your food. Then enzymes and saliva start a reaction of beginning to break down food. It's swallowed. Esophagus, that muscular tube, works that food down to the stomach, and then the stomach does its magic. It's the main digestive organ. Hydrochloric acid and other digestive enzymes are churned and in the stomach through muscular contractions of the stomach to help break down that food, and some nutrients, some medications. If the patient's taking an oral medication, are absorbed in the stomach. Coming down the esophagus, you have the cardiac sphincter. The sphincter is just a muscle that contracts so that it's like closing a hatch. So coming down the esophagus, at the terminal end of the esophagus, at the superior portion of the stomach, the chewed food material and liquids pass through the cardiac sphincter into the stomach, and then after the digestion takes place in the stomach, then the material passes through the pyloric sphincter, and the digestion continues from there. I got ahead of myself. How does the liver assist in digestion? Liver adds bile, and that aids in digesting fats. The liver also helps filter out toxins and creates glucose stores. Gallbladder, its purpose is it's part of the biliary system, and the biliary system provides that bile used in digestion. Bile comes partially from old, dead, worn out, broken down red blood cells that are reabsorbed and broken down in the liver or in the biliary tract, and then that bile moves into the stomach through the common bile duct to aid in digestion. The gallbladder, which is the source of considerable problems for some people, the gallbladder is a storage tank. It's a reservoir for bile, and when the body needs the bile is released into the stomach. If somebody has a cholecystectomy, that's the surgical removal of the gallbladder, do they still have bile available for digestion? Yes, they just don't have a gallbladder to store it. And that bile still moves through the common bile duct and into the stomach. And some people continue to develop gallstones that are large enough that they can block that common bile duct and cause problems to redevelop. Let's move on down. The small intestine, the proximal portion is the duodenum. That mixes, your book calls it digestive juices. That works for me. Good enough. From the pancreas and the liver, pancreas releases several important things. Sure, you were already familiar with the pancreas and insulin before you ever took this course, but amylase and bicarbonate are released from the duodenum. And I'm a Texan. I've probably pronounced this word wrong for my entire adult life. I still say jejunum. I've heard it pronounced better ways probably, but you're stuck with me. So now I'll program a mispronunciation into your head probably. There's absorption of digestive products, nutrients, and medications, more medications absorbed there. This is the longest portion. The jejunum is the longest length of the small intestine. It's the workhorse. It's what really works over the digestive material received from the stomach and the duodenum. And then the terminal portion of the small intestine is the ileum. That's the very distal portion. To find the ileum, it's roughly, if you find your iliac crest, which is the top of that big bone in your hip, on the lateral side, the mid-axillary line, hopefully all of those topographic anatomical reference points mean something to you. And then you find your umbilicus about halfway between the two. That's where that's the area of the appendix. And if you move medially, let's say about maybe 5 centimeters, roughly, that's the area of the ileum. That is where the small intestine terminates and connects with the large intestine. The cecum, C-E-C-U-M, I think, is that portion that the ileum connects with. I was trying to think of a better term for connect. In the ileum, bile acids are recirculated, right? They're absorbed, and they return to the liver to be recycled and used again. And then vitamin B12 is absorbed to be used for making nerve cells and red blood cells. Red blood cells are produced in the bone marrow. That's why we can do interosseous infusion and administer medications through an IO line. We have a direct connection to circulation through the bone marrow. Colon is large intestine. It finishes up the job. Peristalsis, if you think of a garden hose and you think of starting at the spigot and headed toward the sprayer nozzle on the end, if you could think of a muscular wave that squeezes back and forth, squeezes in and out down the length of that garden hose, that can give you a mental picture of what peristalsis does and how it moves waste on through the intestines. The balance of water is absorbed as peristalsis works the waste material on through the large intestine. So what happens if that waste material doesn't stay in the colon long enough, or if the colon isn't doing a good enough job of peristalsis, or if peristalsis happens too fast, that water isn't removed, or that water isn't absorbed and removed. So that would be the connection with peristalsis and diarrhea. So if you have irritation, infectious irritation of the colon, so that it doesn't remove the liquid as the waste moves through the intestines, then you get that watery stool, or that loose stool, as we call it. Stool, that's the fecal material that in the healthcare world, that's the rest of the world calls it poop. We call it stool, unless we're talking to our dogs or our kids. Because you don't ever ask your dog, do you need to go stool? You go poop, let's go poop. That's okay. Spleen, 40 years ago, 35, 30 years ago, when we taught these courses, we were still saying what we were taught, that the spleen is a vestigial organ, meaning through the evolutionary process, the body had leftover organs that it didn't need, but they're still there. They serve no purpose. And if there's a problem, we just surgically remove them and go on with life. What they determine with the spleen is it is of vital importance. The spleen is part of the lymphatic system. It not only, we knew all along that it filtered blood, but the liver also filters blood. So the thinking in medicine was the liver will cover the job. The spleen is superfluous, and we can cut that sucker out and send it for pathology and call it good and dispose of it in the city dump. I don't know what they did with them. I think they burned them actually, but the spleen produces antibodies. It has a vital role in defending the body against disease. Without the spleen, they noticed in patient after patient after patient, times tens or hundreds of thousands of people, that they were more prone to illness, that they didn't develop immunity as they should when they were exposed to viruses. So that the whole thinking in medicine changed about 30 years ago, so that they work hard to try to salvage the spleen and maintain the good grief, sorry about that, maintain that for the protection for your patients. All right, I'll stop there. I think I made my point and I can't find the words I'm looking for. Male reproductive system. Testicles, this is starting at the testicles and moving around toward the penis. Start with the testicles, and then on top of each testicle is epididymis, and then tubular structure called the vas deferens, and you don't say vas deferenses, they're vas deferentia. Other than testicles and the penis, we don't see in EMS the rest of these structures. We just know that they're there. And you have seminal vesicles, prostate gland, and penis so that is male, female, ovaries, fallopian tubes, uterus, cervix, vagina. What's the function of the urinary system? Discharge the waste material that's been filtered by the kidneys. Kidneys filter massive amounts of blood. We barely touch on the kidneys in this class. Kidneys are at the same time simple and extremely complex. They, like I said, they're retroperitoneal, so they're behind the posterior wall of the lining of the abdomen, if that gives you a better picture of that. Any of us who have ever been hit in the flank, you have a really good idea where your kidneys are, because that can be extremely painful. That's not something girls do to each other in the halls of the high school, but every now and then guys will just, instead of walking up and saying hi and shaking hands, they'll do something stupid like punch their buddy in the in the kidney. So don't do that, and teach your kids not to do that. But if it ever happens to you, I guarantee you'll remember it, because it was extremely painful. Had it not been a friend, one of us would have ended up with an eye that looks like mine. Oh man, I just touched that. Hopefully I didn't make it bleed. All right, if I have blood running down my face, we'll take a break early. So you can yell and tell me if I'm bleeding here. All right. Your kidneys are major portion of maintaining your blood pressure through the renin-angiotensin system that we will talk about when we talk about shock, or talk again. We do have another lecture down the road right before trauma on the pathophysiology of shock, so it's a repeat because it's important. So we'll talk more about the renin-angiotensin system then, and then through the absorption, or the retention or the excretion of bicarbonate. The kidneys are involved in the acid-base system, helping maintain that very narrow range of pH that the human body needs, 7.35 to 7.45. That will mean much more to you when you stick around for paramedic school. And then after the process of filtration, the toxic waste can be removed. Medications, the body recognizes medications as toxins in a lot of ways. So if you've ever had to have a drug screen for a job or for a college class, believe it or not, we're going to have to start doing that for clinicals in the fall. But if you've ever had a drug screen, what are they looking for? Your body's working to rid itself of what it recognizes as a toxin. So the medications are filtered out and then discharged as waste in the urine, high blood flow to the kidneys. So if you have a patient with blunt force trauma that causes hemorrhage in a kidney, you have a patient who can bleed to death on you really quickly. Not everybody's born with two kidneys. Most of us are. I have a neighbor, I didn't know this until last week, came up in conversation. I only have one kidney. I said, oh, yeah. Have surgery and have it removed? Nope, they told me I was just born with one. It's an extra large one to cover the job, but just have one. All right, that's good to know, since we were talking about a guy trimming your trees. Weird how things come up in conversation, right? Ureters connect each kidney to the bladder. The bladder stores urine. It's a holding tank for urine until the bladder expands to the point that the specialized nerves called stretch receptors start to cause you to have the feeling of fullness and give you the urgency to void your bladder. So those stretch receptors are sending signals that tell you you need to take care of something, or your body's going to take care of it for you, and that could be quite embarrassing, especially if you have light colored pants on, right? Okay. From the bladder through to the outside world, the urethra is what makes that connection. That would be the terminal portion of the urinary system. This says that the body produces at 1.5 to 2 liters of blood per day, of urine per day. I think it's probably more than that. Again, if you're a picture person, here's something important though. Particularly with hospitalized patients, they keep track of what's called an I&O, not the letter N, but I and O, and that's intake and output. So something important that we have to track is whether our patient has, whether they're retaining liquids or whether their output is more than their intake, which would eventually cause them to become dehydrated so that we have to adjust their intake. Those should remain fairly close in relationship to one another. So that's not something really that we keep track of pre-hospitally. In the ALS world, we'll keep track of the total amount of IV fluids that we infuse. So that becomes part of that intake and output tracking. There is another picture from your book. One kidney lies a little bit higher than the other, and then the ureters, that is where part of the pain from kidney stones, renal calculi, comes from. Once the kidney stones make it into the bladder, then round 2 of pain happens as those kidney stones make their way down the urethra. In females, the urethra is shorter. That doesn't mean that it doesn't hurt extremely bad to discharge the kidney stones. I've heard that pain described as peeing out ground glass, if you can imagine that. Or if you've ever fallen in a sticker patch when you were a kid, those goat heads, whatever you call them in your world, but those little suckers, those kidney stones, they come in all different sizes and shapes. But if you can picture, what's another name for a sticker? A cucklebur is a different kind of sticker to me. But if you can picture all those little points on that semi-spherical or oblong thing that you step on that hurts your foot, and just imagine that making its way down through the ureters into the bladder and out the urethra, that should send shivers up your spine and make you realize how much pain your patient can be in from that. All right. I've mentioned the peritoneum as the lining of the abdominal cavity. That's the parietal peritoneum. Visceral peritoneum covers organs. Blood, pus, bile, any foreign material that is free in the abdomen can irritate the peritoneum and cause an inflammatory process that we call peritonitis. Acute abdomen, that doesn't mean one that looks good at the beach. Acute abdomen, a sudden onset of abdominal pain. That's a symptom of a severe underlying problem, and that problem is going to progress and continue to get worse and can eventually take our patient's lives. So these are intense problems that have to be definitively managed in a hurry, or your patient is going to have a problem. Mentioned peritonitis already. There's your definition: inflammation of the peritoneum. It can cause an ileus. What is an ileus? It is, just think of that garden hose, that muscular tube that is moving fecal material and gas along, and part of that tube becomes paralyzed and it doesn't work anymore. So what happens? It's an interruption in that muscular contraction that moves things along through the colon, and it causes the system to back up. That causes stretching and distension, which causes intense pain. So that is something that they really keep an eye on with the patient in the hospital. It's a very serious thing when a patient develops an ileus, and that paralyzed piece of the colon, or the ileum, I'm sorry, of the ileum, can cause cessation in blood flow, which can cause a weak area, which could lead to rupture as that distension and pressure builds. And if that ischemia leads to actually death of that muscle tissue, that can become a weak place, which can lead to perforated ileus, which spills all of that gas and fecal material into the peritoneal cavity, and your patient can become septic and die really quickly. Diverticulitis, small weak portions of the muscles in the muscle walls in the colon. That's not something we're going to diagnose pre-hospitally. Starting in the late 1800s, in the industrialized world, people's diets started to include more and more processed foods and packaged foods, and that led to more firm, more solid stools, which causes the colon to have to work harder to move that along, and that more intense squeezing of the colon can lead to those little weak pockets along the way in the muscle wall. And it's just, if you can picture, if you know what the Greek letter omega looks like, it's that short line with a partial circle and another short straight line. That's omega. And if you can picture those along the muscle walls of the large intestine, that is each one of those would be a diverticulum. Signs and symptoms of diverticulitis: abdominal pain, bloating, diarrhea at times, can be an intense, painful thing. And then going hand in hand with that increase in processed foods in our diets, the instance of colon cancer in the industrialized world has greatly increased as well. So after you're 50, you're supposed to go have a colonoscopy. That's when they take a camera that's on the end of a long tube and they drive the wrong way up a one-way road, and they go check out your colon, and they make it all the way up to the cecum, which is the connection, remember, of the where the small intestine and the large intestine come together, and then going from the other end when they do an EGD, and that's, oh good Lord, I can't get there with what the acronym stands for, but they give you conscious sedation, and they take a scope, a long tube with the camera on the end, and they go down through your mouth, down your esophagus, in your stomach, out through the pyloric sphincter, and they can make their way all the way around, and using that scope they can go check out your common bile duct, and they can even retrieve gallstones from by using that scope. So that's an ERCP. Oh good Lord, esophageal retrograde choleogram or something like that. Anyway, that's and they give you pictures to take home when they do that. I went with my mom and took her a couple of years ago, and while she had an EGD with an ERCP, and they brought pictures out for us to show us what they saw in there, and I have a file with my mom's medical records here, and I have pictures of her common bile duct with gallstones partially blocking that. Okay, let's keep moving. Talk about two different types of nerves that innervate the peritoneum, and we mentioned this briefly to talk about two different types of pain that patients have with infectious processes or inflammatory processes in their abdomen. The parietal perineum or peritoneum, nerves that innervate the parietal peritoneum, that's the lining of the abdominal cavity. Those are the same types of nerves that innervate our skin. So that lining of the peritoneum, same nerves that sense pain, touch, pressure, heat, cold. The biggie here would be pain and pressure. And parietal pain it can be generalized, but it originates in the infected area that causes the inflammation and eventually becomes generalized. We have generalized pain and we have localized pain. So what's localized pain? I can take one finger and I can put my finger on the site of the pain. With generalized pain, it's more of a global pain that's spread over a large area. It's poorly localized. Visceral pain, that the nerves that innervate the visceral peritoneum, remember that is the peritoneum that covers the surface of the abdominal organs. That is innervated by the autonomic nervous system that produces referred pain. You can have both. You can have parietal pain and visceral pain at the same time. You could have pain in the right upper quadrant that refers to the right shoulder, and patient has they have fever and they're diaphoretic. That patient is probably having pain that involves the biliary system, they're having, maybe they have a gallstone, something's interfering with the flow of bile out of the gallbladder, or in the case of somebody who's had their gallbladder removed, something's interfering with the flow of bile through the common bile duct. The system's backing up, and that's causing the pain because there's pressure in there. The liver sits in a capsule, and that fibrous capsule doesn't expand much. So when you have inflammation within the liver, whether it's the liver itself inflamed or the gallbladder within the liver, there's nowhere for that to swell and expand. So it starts to put pressure, and that pressure is what produces that referred pain into the right shoulder. I think we have a picture of it in a minute. Yep, there it is. So there is the culprit, inflamed gallbladder that is, it's stretching, and that's triggering pain, and that you can have the parietal pain that causes a localized pain. Then that pressure, that puts pressure on this nerve synapse, and then that refers pain up along the spinal cord and then into that shoulder. What's something else that could cause pain that refers to the shoulder? It is possible to have hepatitis. Now, hepatitis causes inflammation in the liver, and also inflammation related to alcoholism that can cause inflammation in the liver itself. The term for the liver itself would be the parenchyma of the liver, Parenchyma, parenchyma, yeah, parenchyma, Parenchyma, parenchyma. That's the structure of an organ. That's the actual body of an organ itself. So hepatitis causes inflammation of the parenchyma of the liver, which can cause that referred pain to the shoulder. Ulcers. Let's take a 5-minute break before we have ulcers. How about that? Ulcers. Okay, picture your stomach, that big hollow muscular organ that is in the superior portion of your abdomen, slightly sitting off to the left. So it's partially in the right upper quadrant, and then mainly in the left upper quadrant. And it's full of hydrochloric acid. And what does acid do? It eats stuff, right? So, and hydrochloric acid, if you ever played with it in a chemistry lab, can be a very strong acid. In fact, in the human body, it is a strong acid. It's very important in digestion. So what keeps that acid from eating up the stomach muscle? You ask, so I'll answer it. That there is a mucosal lining mucosal layer, a protective layer of snot, kind of, that lines the stomach, and it keeps that hydrochloric acid from eroding and digesting the stomach. When that layer of mucus, it can thin out or almost completely disappear in an area, and that allows that hydrochloric acid to start eating into the stomach, and that causes gastric bleeding. That would be upper GI bleeding. So think of we break the GI tract up into upper GI tract, lower GI tract. that division would be above the pyloric sphincter or below the pyloric sphincter. So bleeding in the stomach, esophagus, that would be upper gastrointestinal bleeding, and then below that would be a lower GI bleed. Those produce very different, what I'm trying to say, upper GI bleed that can cause nausea and vomiting, causes gastric irritation and can cause nausea and vomiting. And if you have a perforated ulcer, an ulcer that has eaten into the stomach, and the stomach muscle itself is bleeding, then that patient can have hematemesis, bloody emesis. And if it's a lower GI bleed, then you're going to have blood in the patient's stool. So that's the reason for that differentiation. But we're talking about ulcers right now. So peptic ulcer, it occurs roughly equally in men and women, and more frequently in the geriatric population. As people age, that mucosal lining of the stomach can start to thin out, and that can lead to more difficulty with ulcers. Everything just gets old and wears out and doesn't work as well as we get old. The alternative isn't all that attractive to me at this point, so I'll stick with problems rather than a speedy exit from the stage of life. So patients with a peptic ulcer, what do they describe? Which would be what? If the patient describes it to us, it's a symptom. So what symptoms do these patients have? They have, as their stomach empties, they digest and process their food. The stomach empties and moves the partially digested material through the pyloric sphincter and into the duodenum and on down. Stomach empties, and that acid doesn't have the food material to work on, so it goes to work on the next best thing, which would be the lining of the stomach and the stomach muscle itself. So they describe pain that they have, burning, gnawing pain in their stomach, in their epigastrum. That find your costal arches on both sides. So start with go down your sternum. Now find your xiphoid process, and then your costal arches, that lower margin of your ribs that goes out from right there by your xiphoid, and your epigastrum is that area where you get a bellyache, up there when you have nausea and vomiting and you have abdominal pain. Often you're having epigastric pain. So these patients have epigastric pain. It's a burning, just gnawing pain, just like something's eating away at their stomach. Why? Because it is. So they have, and when does it get better? It gets better after they eat. And so they have a patient with a burning, gnawing pain that diminishes after they eat a meal, likely has a peptic ulcer, and that requires medical intervention. Patients can also have nausea, vomiting, belching, heartburn. Why do they get heartburn? Heartburn is when the hydrochloric acid, the digestive acid, makes its way past the cardiac sphincter and up into the esophagus. The esophagus is not designed, it has a mucosal layer, but it's not designed to be able to handle that hydrochloric acid from the stomach. So heartburn is when that hydrochloric acid makes its way past that cardiac sphincter. Various things can cause problems with the cardiac sphincter and allow for reflux, EGRD, esophageal gastric reflux disease. That's heartburn. If that persists long enough, that can irritate the esophagus to the point that cells can start to become precancerous and then eventually develop esophageal cancer. And esophageal cancer is one of the fairly difficult cancers to treat. So that's those go hand in hand. That's something else they're looking for when they do an EGD, is looking as they go down the esophagus. They're looking for changes in the appearance of the esophagus, and then they'll do biopsies. They'll take little samples, and then if you have precancerous cells, they have a certain appearance. So they're called columnar cells, like a column, and then add AR, columnar epithelial cells, and that is a condition called Barrett's esophagus, which is a pre-esophageal cancer cell, and something they start to watch really closely. All right, gallstones. Moving on. Let's get out of the. Oh, another thing. Another cause of ulcers is actually something that was discovered in veterinary medicine. In fact, vets have known this for 60 or 70 years, that H. pylori bacteria can cause ulcers. And if in fact your patient has ulcers caused by H. pylori bacteria, what do you think one of the treatments of that would be? You're right. What's the word for it? Good grief, buddy. Antibiotics. That's the word for it. Antibiotics are used to treat those ulcers caused by H. pylori bacteria, and we got that from veterinary medicine. You might not be excited about it, but I'm excited about having the Texas Tech Vet School here in Amarillo research on all kinds of stuff, because we have now pharmacy school, soon to have the vet school. A year from August, the first class will start, and then we have the third and fourth year Texas Tech medical students, and then Texas Tech residents here. There's going to be some really cool research done here in Amarillo, and Amarillo could well be involved in the development of new medications, all kinds of stuff. So that's going to be really cool. All right, let's move on. Gallbladder. Talked about what the gallbladder does. I've mentioned that gallstones can form, and it's like a little rock that forms in the biliary tract. I should get my mom's permission and scan in the pictures from her ERCP so that people could see what those gallstones look like. But and you can also see what the inside of the biliary tract looks like. But those stones, it's like a little rock that forms, and as long as those are small enough that they're making their way through the common bile duct, and I said the common bile duct, it empties into the stomach a minute ago. I believe it empties into duodenum actually, but as long as the common bile duct, those are small enough they're passing through the common bile duct, then the patient is asymptomatic. A means no symptomatic, no symptoms. So patient's asymptomatic. You've probably heard too much of that on the news lately too with all the COVID-19 stuff. But the patient is asymptomatic as long as those stones are small enough that they're passing through the common bile duct and not restricting the flow of bile. When it becomes a problem is when you either have a clump of those gallstones or really large ones that block that common bile duct, and that causes it decreases the flow of bile, and then that's when your patient becomes symptomatic. We're talking these symptoms appear 30-ish, I think it should say, around 30 minutes after a high fatty meal or at night. A lot of times these, what we might call acute cholecystitis, the rest of the world calls gallbladder attack. Those happen in the middle of the night also. Patient develops severe pain, nausea, vomiting, indigestion, bloating, gas, belching, and right upper quadrant pain that refers to the right shoulder. This is intense stuff. You can take what you would think to be a big, strong, tough man who could handle anything, and you throw a gallbladder attack on them, and they're crying for pain meds and can barely make it to get on your cot so you can transport them. So it's very painful. Another thing that can cause this would be a spasm of the common bile duct. That doesn't necessarily have to be a stone that is blocking that bile duct. It could be a spasm of the bile duct, common bile duct, that's causing cholecystitis. Who is at risk? All of us, but some of us have a higher risk of developing cholecystitis. Women, older folks, fat people like me, people of Scandinavian, American, and Hispanic descent. So what do I have out of that? I'm getting older, obviously. I'm bordering on that obese thing. Scandinavian and Native American descent, man, I may be a ticking time bomb here. I pray that is not the case, because I do not want to have that. How is this treated? Quite often your patient's going to have a cholecystectomy. It's a surgical removal of the gallbladder, and that can resolve in most people that will resolve the problem. In some people, they will continue to produce stones or have spasm of their bile duct. Pancreatitis. Cholecystitis can eventually become life-threatening. In my mind, the way that typically becomes life-threatening, unless the gallbladder perforated and the patient died of septic shock, the progression, the pathophysiological progression of cholecystitis, if untreated, can lead to pancreatitis. The biliary portion of the pancreas has back pressure from the bile that's being produced not being not having unrestricted flow through the common bile duct. So cholecystitis backs the system up. That causes pain, but that also starts to cause pressure in the pancreas, which leads to inflammation. So that inflammation, what can that cause? That can cause the pancreas not to function properly. What else does the pancreas do? In the next chapter, we'll talk about diabetes. So can have some diabetic type issues with pancreatitis. We'll talk a lot more about that in another 20 minutes probably. Okay, signs and symptoms. Pain in both upper quadrants of the abdomen, nausea, vomiting, abdominal distension. That doesn't help a whole lot, does it? That could be all kinds of things. That's why we don't diagnose these things pre-hospitally. Number one, we're not doctors, so we can't diagnose, but we can't develop a clinical impression of what is our patient's underlying problem causing their GI symptoms. But pancreatitis is a very serious deal. Appendicitis, that's the appendix. Remember how I described that, how you find your cecum and ileum halfway between the umbilicus and the iliac crest, that top part of the lateral side of that ileum that makes up your one of the three bones that make up the pelvic girdle. On each side you have two ilii. Your iliac crest, halfway between the two of those is a landmark called McBurney's point. Patients with, and that is the general area of the appendix. If you have a patient with right lower quadrant pain, nausea, vomiting, fever, chills, and they have rebound tenderness at McBurney's point, and I'm going to tell you all of this, and then in a second I'm going to tell you not to do it. But in the old days, we would locate McBurney's point on our patients who had nausea, vomiting, anorexia, fever, chills, and we would press in firmly with our fingers, our fingertips at McBurney's point. And did it hurt when we pressed in? No, with appendicitis, it doesn't hurt when you press in, but when you let go, because of the inflammation to the parietal peritoneum, that peritonitis that's developing, that causes intense pain. That's called rebound tenderness. So why did I tell you where it is and what it feels like to our patient when we press on it with our fingertips, and then I tell you not to do it? We don't want to take a patient who has inflammation of the appendix, they have appendicitis, and cause them to have a ruptured appendix so that they're spilling fecal matter throughout their peritoneal cavity. So then we cause somebody to have eventually have septic shock. So rebound tenderness. Also in the old days, you would see doctors walk in and you had a patient who had these signs and symptoms, and they'd walk in and take if you picture this as the sole of the foot and this is the heel, they'd walk in, take their hand and bump the heel like that, and that impact would transmit up the leg, and that would cause rebound tenderness. Occasionally you still see somebody do that I'll tell you, if somebody has appendicitis and they have these signs and symptoms, we're still going to palpate their abdomen for rigidity, but we're not going to palpate the right lower quadrant. But as you palpate the abdomen, just pressing and releasing the abdomen as you work your way around the other three quadrants can elicit rebound tenderness. Also, every bump you hit as you're rolling the cot and you bounce over something on the sidewalk, every time the ambulance hits a bump in transit to the hospital, that can cause rebound tenderness. So it's usually very apparent if your patient has rebound tenderness. All right. GI bleed, gastrointestinal hemorrhage, mentioned that already. You can either have an acute GI bleed that perforated ulcer that starts to cause bleeding into the stomach and causes nausea and vomiting, and they have bloody emesis. That could be an acute bleed. Your patient could have colon cancer and have that perforate the colon and cause them to have hematochezia or bloody stool. It could also be that it's not an acute bleed, it's not a big time lower GI bleed, so that it could be that there are just small bleeds within the colon, and that causes occult blood, OCCULT, but it doesn't mean devil worshippers. Occult blood in the stool. So it's not obvious from the stool that there's blood in it, but your patient is slowly losing blood. They become anemic. They don't feel well, obviously, feel weak, and go to the doctor, and they do what's called a WIAC test. They do a digital rectal exam, and they have a little card that has some reagents on it, and they smear that stool. You wear gloves when you're doing this, by the way. You smear that stool on that card, and if the iron in the blood will react with the reagent on the card, and it causes it to change colors. And that's one of the ways that they'll initially diagnose a chronic lower GI bleed. And then from there, they take a scope, drive the wrong way up the one-way road, and they try to go in and determine where that blood's coming from. And hopefully they can even manage that with the scope and manage that medically. Occasionally the patient has to have surgery. Esophagitis, it's inflammation of the lining of the esophagus. That could be chronic heartburn, nausea, vomiting. That acid coming up into the patient's mouth. Again, that you have a mucous membrane inside that lines the inside of your mouth, but it's not designed to deal with that hydrochloric acid, so it starts to cause sores inside the mouth. Esophageal varices. Esophageal varices are bundles of capillaries in the esophagus itself that can cause heartburn and symptoms of esophagitis, but those varices can eventually rupture, and a ruptured esophageal varices causes massive blood loss. A good friend of mine died from a ruptured esophageal varices. He was a bad alcoholic, and the inflammation in the liver causes it restricts blood flow leading from the esophagus back to the stomach. And as that backs up, eventually it starts to distend those capillaries and cause those varices. And then that ruptures. They crash in a hurry and they die really quickly. If you have a patient who is vomiting up bright red blood, and they have massive amounts of bright red blood coming out of their mouths, be thinking esophageal varices. We need to treat for shock and call for ALS to rendezvous with us on the way, and we need to beat feet and head to the hospital. They may not make it. They bleed out in a hurry, but there is a chance of getting them down to the GI lab and going in with the scope and cauterizing those areas that are bleeding. What is cauterizing? Take electric current and burn bleeding blood vessels to stop bleeding. So that's quite often patients with esophageal varices are alcoholics. They have fatigue, weight loss, jaundice, anorexia. They don't want to eat, but they'll drink, right? And they have abdominal ascites. That is free fluid in the abdominal cavity that causes like a squishy, watery kind of distension of the abdomen. That is what ascites are. And then abdominal pain. And then and they have quite often, my buddy drank, not only did he drink a half gallon of scotch a day, but he drank tons and tons of Maalox and Pepto-Bismol, that kind of stuff, antacids, because he had horrible heartburn all the time. He thought he just had and he was a paramedic. He thought he just had esophagitis from all the booze he was drinking, and he liked hot food for a while. Spicy food until he got to where he didn't eat at all. That was when he was up to half gallon of scotch a day. Wasn't good scotch because paramedics can't afford a half gallon of good scotch a day, so that's a lot of booze. Yeah, all right, let's see. Mallory-Weiss syndrome, I mentioned that very briefly. Another potential cause of vomiting up bright red blood is Mallory-Weiss syndrome. When do we see this? If you have a patient who has suffered violent vomiting, they're vomiting, and it's just, you've like the projectile vomiting kind of thing. This was a few years ago when people went to see The Exorcist at the drive-in movie all the time. I would tell you that it's kind of like when the demon-possessed girl pukes up the green puke all over people, but you just think of violent vomiting that goes on, and it's just intense, and that can cause a tear at the junction where the esophagus and the stomach connect, and that rips, and that would be Mallory-Weiss syndrome. Again, we can't diagnose that pre-hospitally, so that's, again, we don't stay and play. We're gonna load and go, rapid transport, manage your. You may not get past your primary survey and the treatment for the life threats you're finding. You may rendezvous with ALS on the way to the hospital. If you're 30, 45 minutes away from a hospital and there's a helicopter available, it's a good time to call for a helicopter. These patients require rapid transport and surgical intervention to have a chance of surviving. Gastroenteritis, that's when you have a GI virus and you have diarrhea, abdominal cramps. Can either be have a bacterial or a viral cause. Uh, Gastroenteritis isn't transmitted person to person, but the virus that causes and the bacteria that cause gastroenteritis may be transmitted person to person via the fecal oral route of transmission. That is exactly what it sounds like. You could turn into a germaphobe pretty easily. It's you wash your hands, you wash your hands, you wash your hands, but if other folks don't, these things can spread. Talk a lot more about that in my medical emergencies class for paramedic students. But already talked about diverticulitis. I don't know why it's in the dang PowerPoint twice. Hemorrhoids, bright red blood during defecation. Hemorrhoids are inflamed blood vessels surrounding the rectum, and they bleed. They bleed bright red blood. Sometimes it's a little bit, sometimes it's a lot. It's not unusual to get an ambulance call on a patient bleeding to death in the middle. It seems like it's in the middle of the night. Those are the ones you remember. If you're working a 24-hour service, those are the ones that somebody decide they have to get up and go have a bowel movement at 3 in the morning, and they wipe, and there's this bright red blood all over the toilet paper, and they freak out, and they call 911, and we all roll up and go in, and they start to describe what happened as we get our sample history from them, and we discover there's probably a good chance they have hemorrhoids, but they need to be evaluated to make sure. Cystitis, bladder infection, also called a UTI. Quite often, it's the patients that require EMS transport most often with UTIs, I think, are probably long-term care patients with urinary catheters or Foley catheters. Maybe that because of urinary incontinence, they require a Foley catheter. If you just put a diaper on them and that diaper has urine in it constantly, it can start to irritate the skin and start to cause the skin to break down. So they'll place or if they just absolutely can't void, for some reason they can't pass urine and they can't void, they may also have to be catheterized to urinate. And if it's a lot of long-term care patients end up with a Foley catheter, and I don't know if the Foley family gets royalties every time I say that or not. Patient ends up with a Foley catheter. That was a joke. You could laugh, but never mind. Okay, probably Dr. Foley invented it. But, so they have a bladder infection. Bacteria can grow around that urinary catheter, usually starts down there at the distal end of the urethra, and then it starts to the bacteria grows, moves up the urethra, eventually into the bladder, proliferates in the bladder, and that causes cystitis. When it becomes a critical situation is when that infection spreads to the kidneys, and those infected, inflamed kidneys don't work as well, and they get inflamed and they start to swell, and that can interfere with blood flow to the kidneys. And long term, eventually, if your patient didn't die of septic shock first, they might die of renal failure. That could cause the kidneys to cease to function. Okay, signs and symptoms, frequency and urgency. I go to the bathroom all the time. Frequency, urgency. I feel like I have to pee all the time, so I go to the bathroom all the time. And add another to that would be burning, painful urination. So urgency, frequency, painful urination, fever, low-grade temperature. Our little nursing home patients with altered mental status, if they have a Foley catheter, they have altered mental status, they're unconscious, unresponsive, and they have fever and signs and symptoms of shock, it could be that they're becoming septic secondary to cystitis. So that would be a life-threatening condition. That would be the signs and symptoms you'd see. One of the major components in homeostasis in the human body is having functioning kidneys. They eliminate waste products from the blood. So what happens, I mentioned renal failure a moment ago. What happens when kidneys fail? A condition called uremia results. That urea is an acidic waste product, and your patient can they can start to become acidotic, and then that uremia in the kidney can also cause renal calculi. That uric acid can cause renal calculi, and that can lead to the kidney stones. Renal calculi can also they can be caused by sodium and potassium salts. There are various kinds of kidney stones. Can we determine that pre-hospitally? No. Same signs and symptoms. Acute renal failure, it's a sudden decrease or cessation in kidney function. If it's treated quickly enough, if you have prompt diagnosis and treatment, and we're not talking pre-hospital treatment, if there's prompt diagnosis and treatment, the kidneys can recover and begin functioning normally again. Chronic renal failure normally progresses over time. It's irreversible, and it's managed either with dialysis or a kidney transplant. One of the couple of causes of chronic renal failure, which leads to the cessation of renal function, one would be chronic untreated hypertension. That increased pressure damages the kidneys and can eventually lead to kidney failure, or diabetic with poorly controlled blood sugar can also lead to kidney failure. Okay, you know what the female reproductive organs are. We're going to spend a whole chapter on obstetrics and gynecology. If you have a female patient, childbearing years with acute abdominal pain, we're going to treat them as if they're pregnant and as if they have a problem resulting from that. So could be an ectopic pregnancy, which is where the embryo implants in the fallopian tube itself, starts to develop to the point that that fallopian tube ruptures and your patient bleeds to death. They could have ovarian cysts causing lower quadrant pain. They could even have perforated or ruptured uterus that's causing pain. But we'll spend a lot more time on that later. Don't forget, we talked about this last week in cardiac emergencies. We're going to repeat it again briefly. Remember, in patients with that sudden onset of that tearing, ripping abdominal pain, that could well be a ruptured abdominal aortic, or dissecting abdominal aortic aneurysm, AAA. Sometimes it's pretty obvious to us that that's what's going on. You're palpating someone's abdomen, and as you palpate, you run across a pulsating mass that, oddly enough, seems to be in sync with their pulse. When you take their pulse, get your hands off. Don't poke on that thing anymore. You don't want to apply pressure and cause that dissecting aortic aneurysm where those layers are weakened and start to get like that big bubble on the sidewall of a tire, like I mentioned last week, or that big bulging place in a garden hose. She's at risk of blowing. You have that big weakened place, and pushing on that, palpating that can cause that to rupture, and your patient crashes and dies because we have just ripped a hole in the largest artery in their body. So we don't do that. If you find that pulsating mass, yes, there it is, move your hand. Don't. If you have a patient who has that sudden onset of that tearing abdominal pain that radiates to the back, and they have unequal femoral pulses, then you could well be dealing with an abdominal aortic aneurysm, and you be very careful when you palpate their abdomen. Okay. All kinds of medical conditions can lead to an ileus, so I'm not going to spend much time there. Hernias, that's a protrusion of organ or tissue through an opening in the peritoneal cavity, and that allows a bulge. Two very common ones. One would be an umbilical hernia. Just picture a giant Audi. Have somebody's umbilicus, and it bulges out big time around. Instead of having, I don't know who has innies and outies, and I don't want to know, but that normal appearing umbilicus bulges way out, and that would be one type of hernia. There's a tear in the peritoneal cavity there, the parietal peritoneum there, and that allows that to bulge out. In fact, found one of these on one of my EMT students in lab when we were doing the first patient assessment lab, and one of his classmates was palpating that student's abdomen. This guy was a Marine Corps combat vet, like 4 combat tours under his belt, just a man's man. He seemed to be one tough dude, and when his classmate palpated his abdomen in the area of his umbilicus, he was suddenly in severe pain, and that got my attention, and I went over and said, "What's the problem?" He said, I'm not acting up. My gut hurts." So I start palpating his abdomen and found a large umbilical hernia, and I told him to go we'd take him straight to the ER or call an ambulance. "No, I'll just drive myself." And he actually went across the street to the VA hospital, and then they put him in an ambulance and transferred him over to Northwest. But reducible, you can take that herniated material or organ, whatever is protruding through the peritoneum, and you can push it back inside. That's reducible. it goes back into the body cavity. Another area that you often see hernias are inguinal hernias. Think of the floor of the abdomen, and the inguinal area is, if you picture a line that's roughly from the pubic symphysis, where the two sides of the pelvis come together, and you go at a roughly a 45-degree angle back up, kind of where that crease is when you sit down, and move medially there. That is where the inguinal canal runs. Inguinal canal in males, during fetal development, the testes form in the same place that ovaries form. And then late in gestational development, the testes descend down through the inguinal canals and into the scrotum. And then the peritoneum seals over and should be as strong as the rest of the peritoneum, no problem. But in some people, some males, there's a weak place there. In some females, there's a weak place there. And straining really hard can cause that to tear. And then part of the large intestine protrudes down into that inguinal canal. And reducible, you can push your finger up through the inguinal canal, and we don't do this pre-hospitally. I'm saying that physicians do this, but they follow the inguinal canal up and they push that protruding bowel back up into the peritoneal cavity. That's reducible. That's not an acute, right now have to go to surgery and fix it problem. When it becomes a surgical issue and something that needs to be handled right now would be when it becomes an incarcerated hernia, and you can no longer reduce it. Surrounding tissue, either muscle contraction or inflammation, causes a stricture there that prevents that herniated material from being able to be pushed back into the abdominal cavity. That becomes an emergent situation. Take that to the next level. When does it become a possible life-threatening situation? You have strangulation, that tissue squeezes down enough so that it stops blood flow to the organ or that's protruding through the herniated portion of the peritoneum, and then that ischemia turns into cell death in that organ, and then you have potential for rupture, and then you have fecal material spilling into the abdomen, which can lead to septic shock and death. So that is a right now emergency. So signs and symptoms of a serious hernia. Formerly reducible mass is no longer reducible. Severe pain at that hernia site. Tenderness when palpated, and it gets kind of a red or blue discoloration tint to the skin around that. We need to get them onto the hospital. Supportive care, they may be nauseous and vomiting. Need an emesis bag to catch that in. Low flow oxygen through a nasal cannula can help. Watch for signs and symptoms of shock. You could also call for ALS to come take over your patient, start an IV, administer pain medication, or possibly administer IV fluids if the patient is in shock. Okay. GI bleed. Fecal matter with blood in it has a horrible distinctive smell. I can't tell you what it smells like. You'll know what it is the first time you smell it, and you'll never forget it. And that's the best I can tell you. Mechanism of injury, nature of illness, could be blunt force trauma to the abdomen that caused a problem. Could be that we're just dealing with the medical situations that we've been talking about. Manage the airway, breathing, circulation, determine if this is a stay in place situation or rapid transport. Do you need ALS? Do you not need ALS? Sample history. Remember to ask about nausea and vomiting, changes in bowel habits, urination, any weight loss, belching, flatulence, gas coming out of both ends, right? Pain, what's the pain like? Where is it? Does the pain move anywhere? That's in our OPQRST, right? Are they having any chest pain with it? And then we need to work through our sample history in OPQRST and remember our signs and symptoms of cardiac chest pain. And if there's a question as to whether our patient's chest pain is cardiac in nature or GI in nature, we're going to treat for cardiac. They can deal with the upper GI type pain in the chest at the hospital, or we can call ALS. They can do a 12-lead EKG, and they may be able to make a determination based on that EKG. But we're going to treat that patient as if they're having cardiac chest pain, if there's any question at all. Palpate the abdomen. Remember the exceptions that I've given you. Times you don't want to palpate the abdomen. And remember rebound tenderness, point tenderness, vital signs. Reassess. Q5 minutes for critical, Q15 for non-critical. As always, we're going to reassess our interventions. We're going to start over with relevant portions of our primary survey, especially if our patient has had a change in condition. And then we're going to trend the vital signs. We're going to look for any developing signs and symptoms of shock. Try to provide emotional support to your patient. Low flow oxygen can help a little bit. ALS with a little fentanyl might be very helpful. Transport them in a position of comfort. If your patient has peritonitis to any extent, the comfortable position to them is going to be quite often the left lateral recumbent position. What is that? They're lying on their side, on their left side, and they're going to have their knees drawn up toward their chest, and they're going to bend their upper body over. What does that sound like? They're kind of curling up in a ball because they're trying to take the tension off of that inflamed peritoneum. They don't know that's what they're doing. They just know that helps the pain. The body kind of naturally wants to go to that position. So we're going to transport them in that position, the most comfortable position. Quite often that is the position that they will prefer. Still make sure to secure them to your stretcher. Even though they're on their side, you can still put the seat belts on them. Treat for shock, low flow oxygen, like I said. Dialysis is the treatment for chronic renal failure. Dialysis is quite often the treatment for acute renal failure. Sometimes the kidneys need a little bit of rest and possibly antibiotics to help deal with the underlying problem that caused the acute renal failure. Could also be that just a diuretic drug such as Lasix could help challenge the kidney to jumpstart the jumpstart the kidney. We don't need to go deeper than that. We'll add an hour to the class for no reason, because that's not going to be on an EMT exam in my class or on the National Registry. What is dialysis? It's a machine that functions much like a normal kidney. So it take the patient's hemodialysis, like your patient gets at the dialysis center or in the hospital. They're connected to a dialysis machine. The blood is circulated from the patient, slowly circulated from the patient out through the machine, and various membranes within the machine help to remove the toxins and the waste materials from the blood, and then the blood is returned back to the patient. So following dialysis, your patient can have some adverse effects. Where would we become involved? Well, we don't work in dialysis centers for the most part, though some EMTs do. Where we may be called to treat these patients after they get home. Maybe they become hypotensive. Maybe they have severe muscle cramps because of all the sodium and potassium that's been removed from the blood through the process of using the dialysis machine. That can cause muscle cramps, can cause nausea and vomiting. They could have hemorrhaging from the access site. I'll show you pictures in a minute of what I mean by access site. And it can develop infections at the access site. Let's see, there's a better picture. This is an atrioventricular, or not atrioventricular, arteriovenous fistula. Surgically, they go in and create connections into the brachial artery and one of the veins in the, I guess that would actually be the ulnar artery down there, but one of the arteries and one of the veins in the forearm, can even be up in the upper arm. That's how the on the arterial side, blood leaves the patient and goes into the dialysis machine to be cleaned, and then it's returned on the venous side. So you have filtered, cleaned blood going back in. It takes time when somebody's on the hemodialysis machine. It can take an hour or more to filter the blood enough so that they remove fluid from our patient. So if our patient is, if they're a hemodialysis patient and maybe they go for hemodialysis every third day, or maybe they go 3 times a week, 2 times a week, as they get close to that time, they're not, the fluids they drink, the fluids in their intake have to be removed with dialysis. So they may start to become hypertensive. They may start to have generalized edema. Their acid-base balance and acid-base system is off, so they don't feel well. It's what is dialysis for? It's to try to hold a patient over until they can get until they can have a kidney transplant, or in the case of acute renal failure, possibly to manage them, provide dialysis until they can get their kidneys working again. So what is our care? Manage the ABCs, provide high flow oxygen if indicated. That would be if their SpO2 is below 94%. If they have any bleeding from that access site, we need to manage that bleeding. Don't take a blood, if you have in your dialysis patients, take their blood pressure in the other arm. Don't take the blood pressure in the side where that fistula is. These patients can have, because of fluid retention, they can have pulmonary edema. So we need to transport them in a high Fowler's or semi Fowler's position. Provide high flow oxygen, be ready with suction. We can call for ALS. There are some medications that we can give them as paramedics to help deal with that pulmonary edema. Positive pressure ventilation. You could put this patient on CPAP to help deal with that pulmonary edema, right? Or if they can't follow directions well enough, or if they're not conscious and able to follow directions, then CPAP is contraindicated. So they're out of luck, right? We can't do anything for them. No, positive pressure ventilation with the bag valve mask. Place them in the supine position if they're in shock. Prompt transport, rendezvous with ALS, get them to the hospital. Questions about all of that? Let's take 5 and come back, and we will talk about diabetes for an hour, and we will be done. Endocrine and hematologic emergencies. We're going to spend most of this time on endocrine emergencies, and the endocrine emergency that we're going to spend the most time on will be diabetes. And that is the major focus of this chapter. Other endocrine emergencies, there is, other than supportive care, not a lot we can do for them as EMTs, other than provide rapid transport and manage any life threats. So what do we need to know? Okay, if you have a piece of paper in front of you, I want you to draw a scale for me. And I'll draw one so you can see what I'm talking about. I'm drawing mine right now so I can show you. Okay. Can you see that scale? On one side, I wrote BGL. On the other side, I wrote insulin. What you have to know, the very basic thing you have to know in order to understand diabetes and diabetic emergencies is that the blood glucose level and insulin work in opposition to one another. So if insulin is low, see there, insulin, it's low. What does that do? The BGL goes up. Now just picture it the opposite way. If insulin is high, the BGL goes down, blood glucose level. What is high and low with blood glucose level? Range, according to your book is 80 to 100 milligrams per deciliter. So that is 80 to 100 milligrams of glucose per 10 milliliters of blood volume in a sample. Well, that doesn't seem like I'm getting 10 milliliters of blood in that little glucometer when I check a blood sugar. You would be correct, but the machine actually makes the glucometer itself manages all of that. It's magic. I have a good friend who's a retired fighter pilot, and he said anything on a fighter jet that you don't understand as a pilot, that's too complex, or just all kinds of unbelievable electronic stuff there. It's called FM, freaking magic, except for they don't use freaking in the fighter pilot world. So a glucometer is FM if you're a fighter pilot. It's just freaking magic. Okay. the endocrine system is a feedback system, and that manages the function of every cell and organ in your body. Endocrinology is an incredibly complex specialty in medicine. Endocrinology is a subspecialty of internal medicine. It's all freaking magic to me. It's in paramedic school, you'll have to memorize some of the endocrine glands and what controls the production of anyway, there's no reason to go into that now. All right. Hematologic emergencies, very difficult for us to assess, even more difficult for us to treat. But recognizing a hematologic emergency, providing good BLS, and calling for ALS and rapid transport could well save a life of your patient. We don't spend much time on it, but we do spend enough time so you can recognize it and manage it. So I said this endocrine system is a feedback system. It's a communication system throughout the body. Glands secrete hormones. Those hormones circulate through the body, and they send chemical messages. So the chemical substance produced by the gland circulates, and then there is an organ, for instance, the pancreas. The pancreas, when it receives the message that insulin needs to be produced, it increases insulin production. So hyperglycemia, remember that scale, the blood sugar starts to get too high, blood glucose level, the insulin production is going to be increased, and that is going to help bring that BGL back into the normal range. If that doesn't happen, major problems can occur. Other glands produce other hormones. Another one that we talk about in this class, really about the other major one we talk about in this class would be the adrenal glands, sitting on the superior aspect of each kidney. What do? Those produce and release adrenaline. We've talked about that as being the messenger hormone of the sympathetic nervous system, right? Okay. And we talked about this 42 times now, at least. The brain has to have a constant supply of glucose and oxygen. There's another element that has to be there. Insulin helps move, or insulin moves glucose from the outside of a cell into the cell. So without insulin, you have tons of glucose, but the cells are starving for glucose because there's nothing to drive those glucose molecules in through that cell membrane and into that cell. So the cells don't get fed. They starve for glucose, and they can eventually die. Pancreas produces and stores glucagon and insulin. In the islets of Langerhans, in the pancreas, because remember the pancreas, it serves multiple functions, but what we're talking about now, the islets of Langerhans, the alpha cells produce glucagon, the beta cells produce insulin. Diabetes mellitus impairs the body's ability to use glucose for fuel. So in type 1 diabetes, the pancreas is it producing enough insulin, or maybe not producing any insulin at all? Type 2 diabetes is a problem. The insulin is still produced by the pancreas, but the cell membrane becomes resistant to insulin driving those glucose molecules into the cell. If we were in class and I had the whiteboard, I would draw a weird looking cell because I'm just not an artist. And then I would draw a weird looking pickup truck, again, because I'm not an artist. And I would put little glucose molecules in the bed of that pickup truck. And I would write insulin on the side of that truck, and to demonstrate that insulin is the vehicle that moves glucose into the cell for the cell to use. So what happens with type 2 diabetes that we'll talk about in a minute? There's just picture, if you've been to, let's see, just picture a big barricade, and that barricade is impenetrable. That pickup truck with the bed loaded with glucose, that insulin can't go past that barricade and into the cell, so that cell starves for glucose, even though there are truckloads of it waiting outside those barricades. But those barricades are the resistant cell walls that don't allow the glucose in, so the patient becomes hyperglycemic. All right. Long-term complications of hyperglycemia due to diabetes mellitus, the blindness, cardiovascular disease, kidney failure. What happens, the boiled down to its very basics, the high glucose levels, the high serum glucose levels, serum would be blood, so the high glucose levels in the blood causes inflammation of capillaries, and those inflamed capillaries, they start to, as they inflame, the lumen becomes constricted, and that decreases the oxygenated blood flow to the areas, the tissues being served by those capillary beds. So they start to, those organs and structures start to be damaged, and that lead to cardiovascular disease, that inflammation, and those big glucose molecules, big old glucose molecules in the blood start to plug up the kidneys, and that interferes with filtration, because the kidneys just overwhelmed with this giant volume of glucose. And as that starts to plug off the structures of the body, of the kidney involved in filtration, renal function goes down to the point eventually that the kidney may fail. That's why it's extremely important for diabetics to be compliant with their medications and with their diet. The goal is not to have giant peaks and valleys with blood glucose level. It's to have it more of a normal rise and fall, like you have when your body is producing insulin. So that's, or your patient takes the medication to help lower that barricade at the cell wall, so that the pickup truck, which is insulin, is able to drive that load of glucose on into the cell and deliver that, so that the cell can use that for energy. So that process with type 2 diabetics, of lowering the blood sugar, lowering the blood glucose level, usually with an oral medication, occasionally a combination of an oral medication and insulin, to get that glucose into the cell for energy so that can be used up. High blood glucose level, which would be above 100, that's hyperglycemia. Low, which would be below 80, would be hypoglycemia. Your patient over time, if they're chronically hyperglycemic, their body can adapt to an extent and they can function fairly normally for a time, being slightly hyperglycemic. If your patient is chronically hypoglycemic, their body can learn to function with that lower blood glucose level. So I've seen patients who they're symptomatic, but they're conscious with a blood glucose level of 35 or 40. I've seen patients who are hypoglycemic. They have a blood glucose level of 65 or 70, and they have altered mental status or possibly even unconscious, unresponsive from it. So patient to patient, it differs a little bit. I've talked about what type 1 diabetes is, formerly known as juvenile diabetes. That's where there's a problem with the pancreas and the production of insulin. Again, type 2, usually adult onset, that cell wall is resistant to insulin moving glucose into the cell. It doesn't matter whether your patient's type 1 or type 2, depending, and usually hypoglycemia with diabetics result from taking their insulin injection, or they have an insulin pump, an implanted delivery device that delivers insulin, but if they don't have sufficient caloric intake with it, they're not eating, then they can become hypoglycemic. Type 2 diabetics, they take their oral medication, suddenly it moves a big volume of glucose into cells, and that can cause them to become hypoglycemic. Diabetes mellitus type 1, the formerly known as juvenile diabetes. It's an autoimmune disorder. What does that mean? The immune system produces antibodies against those beta cells in the pancreas so that the hormone insulin isn't produced at all, or it's not produced in a sufficient quantity. That does what? That prevents glucose from entering the cell because it doesn't have that pickup truck insulin to drive it in so it can be unloaded and used to produce energy. So the blood glucose level goes up because the insulin level is down. Childhood to 30s or 40s, more often you see late childhood. A lot of times around puberty, can be the onset of type 1 diabetes, and then continuing on into the early 20s, and then after that, you still have people newly diagnosed with type 1 diabetes, but it's less common. And you could have a patient who has pancreatitis that persists long enough that it damages the pancreas, and those beta cells in the islets of Langerhans are destroyed because of that inflammatory process in the pancreas, and they stop producing insulin. And that could occur at any age with a patient who has pancreatitis that persists long enough. So where do these patients, these type 1 diabetes, get insulin? It's an external source. So they either give themselves insulin injections, or they may have an implant. These days, more often they have an implanted insulin pump that senses the blood sugar and blood glucose level and either automatically releases small doses of insulin to deal with that, and the patient there's an external component to it so that they add their insulin to their insulin pump, or the patient has to give themselves injections. How do they know when to give themselves injections? They check their blood glucose level, sometimes up to 6 times a day or more. So and if you're checking your blood sugar 4, 5, 6, 7, 8 times a day, and you're dosing maybe multiple types of insulin, there's fast-acting insulin, there's long-acting insulin, so you're adjusting dosages of insulin injections, you get more of those peaks and valleys, and those hyperglycemic periods can lead to damage to tissues. It can lead to that increased cardiovascular disease. It can lead to diabetic retinopathy. The blood vessels that supply oxygenated blood to the retina in the eye, those can become inflamed and decrease the circulation of blood to the retina, and it causes death, and to portions of the retina it causes, and that inflammation causes changes in the retina so that the patient can eventually become blind because of that. That implanted insulin pump, it continuously measures glucose. Some of the older ones, the patient has to essentially push a button to give them to cause the pump to release the insulin. The newer ones automatically do that, and that maintains more of a normal rise and fall of blood glucose level. When those malfunction, that's when we might come into contact with these patients. If they have an insulin pump, most of the time they're going to know if their pump stops working. They're going to self-transport to their doctor or maybe to the ER. Maybe it malfunctions and it just dumps a whole little bag that you place in that pump. Maybe it just malfunctions and squirts the whole thing in there, and then they're very hypoglycemic. It just depends on what the malfunction is. Your diabetic patients, ask them if they have an insulin pump, ask if it's functioning properly, and you'll be okay. So how do we know when type 1 diabetes is starting to develop because the pancreas is slowing its production of insulin, or it's failing to produce insulin? We have the Pollys, the three Poly sisters. All three sisters' names Polly, but they married different guys, so they have different last names, right? So Poly means increased or multiple. Uria is urination. Dipsia is thirst. Phasia is hunger. So they have increased urination, they have increased thirst, and they have increased hunger. They also have weight loss because their body is starving for usable glucose. They're becoming hyperglycemic. They're just worn out. They're shaky. They're fatigued. Their brain isn't getting sufficient glucose, so maybe they're not thinking as clearly. Eventually, they have altered mental status, and so that what's happening. The scales are tipping, the insulin production is going down or stopping, that blood glucose level is going way up. Why are they so thirsty? Their body is trying to flush out all that extra glucose. They're urinating more because their fluid intake is up, and the kidneys are trying to flush out their kidneys, I guess, for want of a better term. Polyphagia, they're starving to death because the cells of their body aren't getting glucose, so they're getting this horrible signal that we're hungry, you have to feed us. But what they're eating does no good because it's not making its way into the cells. They start to lose weight, they're tired. So when you have we'll get to that in a minute. Anyway, okay. So like I said, it overwhelms the filtration system in the kidney, and when that's overwhelmed, they start to spill glucose into their urine, have increased fluid consumption, severe hunger. Just like I said, glucose is unavailable to the cells. So other than cells of the central nervous system, which can't store fat, even though some of us are kind of a fat head like me today, but they don't have fat to burn as an alternate energy source. Brain cells do without glucose, and mental status suffers before it reaches that point. Other cells of the body are burning fat. That produces an acid waste. It's an aromatic hydrocarbon for you chemistry buffs, and those are ketones. Ketone levels go up in the blood, they spill in the urine. The kidneys can't maintain the acid-base balance. That buffer system in the kidneys, that's a vital component of acid-base balance that keeps us in that 7.35 to 7.45 range. When that happens, the blood becomes more acidic, feeding more acidic blood to tissues, and patient starts to breathe faster and deeper. Those are called Kussmaul respirations. We're talking very rapid respirations, like 30, 36, 40 a minute, and much deeper than normal. What's your patient trying to do? The other component to the acid-base balance of your body is the respiratory component, and that's exhaling carbon dioxide. If patient retains carbon dioxide, that causes acidosis, and pH goes down, and the function of the body suffers considerably and won't live very long if that persists for an extended period of time. So that's why your patient's breathing faster and deeper, because in their brainstem, the chemoreceptors are sensing that the pH of the blood is too low, so that triggers in the medulla oblongata, that triggers more rapid, deeper respiration. So that's how the respiratory system becomes involved, is because of what the chemoreceptors sense, and that is that carbon dioxide level is too high, which makes the pH too low. So that's why the Kussmaul respirations are there. Make sense? It's semi-fuzzy? All right. As the patient metabolizes fat and patient has that byproduct of those ketone levels increase and increase and increase, that's an acid, and your patient develops diabetic ketoacidosis. They present with generalized illness. Well, that helps, buddy, right? That really tells me a lot. I just feel like crap. I feel horrible. I feel weak. I don't feel good. Uh, they have abdominal pain. Well, that's not helping me much. They have body aches. They have nausea. They have vomiting. They're dehydrated. You see poor skin turgor. First time I've mentioned that. Everybody take your arm like this. Take two fingers and pinch some skin up like that, like you're making a little tent for some kind of little creatures to stay in. Now let go. Does it pop back down? Snaps back down, doesn't it? If you're well hydrated, you let go and that skin snaps back down. If your patient is dehydrated, they don't have enough fluid in the tissues, and when you pinch that up like that, it doesn't snap back down, or it snaps back down very slowly. So we added something. Poor skin turgor. That's a sign of dehydration. Sunken eyes. Oh man, what's that? Just what it sounds like. Because of dehydration, it looks like their eyeballs are sitting too deep in the sockets. Poor skin turgor. Maybe they have kind of sunken in eyeballs. I mean, it's still an eyeball shape, but they sit deeper in the socket. So generalized illness, abdominal pain, body aches, nausea, vomiting, altered mental status, polyuria. So they're peeing their brains out, right? They're breathing too fast. They have too small respirations. They're dehydrated. They have poor skin turgor because everything's being flushed through to try to move to manage that uremia and flush that glucose out. So you have a very sick patient. If this persists very long, your DKA patient will pass away. If they have altered mental status so that you can't get a good patient history, you're seeing this presentation. If there are family, friends, nurse in the nursing home, home health nurse who's gone by to check on a patient, and they find them to be present with these signs and symptoms, get that patient history from that person. Well, they're not available. Just police went in to do a welfare check and nobody's around who can give a history. It was just a neighbor who hadn't seen the guy in 4 days, and he's usually out watering his flowers every evening, and after saw the car still in the garage, I knew he wasn't out of town, so called the police for a welfare check because they couldn't get a hold of the son and the daughter, and police go in, and here we find this patient unconscious, unresponsive, and they have too small respirations, they have poor skin turgor, they're unconscious, unresponsive, and we say, oh, we should get a BGL. How can we do that? If we had some magic instrument that we could connect to them and we could see what their blood glucose level is, we'd have an idea what we're dealing with, right? Oh, we do. This is an invasive procedure, so you either have to have a protocol, which is offline medical control, or you have to have online medical control give you an order to break out your glucometer and get a BGL. So you have to be familiar with the operation of the glucometer. You have to get blood on a test strip into the glucometer. I'm not even going to start to tell you how to do it because all of them work different ways. So you poke the finger with the lancet, horribly invasive, right? Poking a little hole in a finger. Oh well, all EMTs should be able to do this all the time. But I'm not a doctor writing protocols. So anyway, so we find that, man, this patient has a BGL of 400 plus and presenting with these signs or symptoms. I might need to be bag assisting this patient's ventilations. Uh, if they have poor cerebral perfusion, we need to be helping get oxygen to that brain. If they're breathing so fast and so deep that they're not exchanging, we don't have respiration, alveolar respiration taking place well enough in the lungs, they can also be hypoxic. So we bag assist their ventilations or provide oxygen via a non-rebreather mask. So there you go. That's type 1 diabetes. Call for ALS. Paramedic can run some fluids in and maybe help bring that BGL down a little bit. Insulin is not a pre-hospital drug at all. If you see that as a treatment option in a question I give you on an exam or a question on the National Registry, run from that option, because insulin is not a pre-hospital drug. So that's going to be done in the hospital in a more controlled environment. It's not that it's beyond a paramedic's scope of practice to administer insulin, but it requires much more frequent monitoring, and it needs to be done in a controlled setting, not in the back of an ambulance or on someone's bedroom floor or in their bed for that matter. Okay. Type 2 diabetes, we talked about that. That's that barricade is up on those cells. We have plenty of glucose. We have plenty of insulin. We have tons of it, but we have barricades and in that cell wall, and we need something to help drive that glucose into the cells, because those cells have become insulin resistant. That's type 2 diabetes. Insulin is still being produced in the pancreas just like always, but it can't get through the cell wall, and that causes blood glucose levels to increase. Sometimes that can be improved with diet and exercise, quite often shuffling in some oral medication, and there are tons of them now, bunches of different oral medications for type 2 diabetes. Some of those oral medications increase insulin production, and that can cause a high risk of hypoglycemia in your patients. Some of them stimulate the receptors in the cell wall that allow insulin to help move glucose through, so that lowers that resistance in that cell wall. And then others decrease the effects of glucagon and decrease the release of glycogen stores. Glucagon is a stored glucose. It's a type of glucose molecule that is released to provide energy to the body as BGL decreases. In fact, say you have a paramedic respond and they cannot get an IV in a patient to give them glucose when they're hypoglycemic, you can give them an IM injection, an intramuscular injection of glucagon to get glucose to them. It's a slower response. It's a much slower way than that IV injection of dextrose, but it still gets the job done. Okay. Other things you see because of that poor circulation. Anybody ever heard you may have heard commercials, or you may tune all these out because they don't apply to you or yours, but recurrent infections, wounds that won't heal, surgical incisions that won't heal in the normal time, that can be from the high blood glucose level and that inflammatory process that prevents oxygen and nutrients from reaching that tissue. So that can increase the risk of infection. That can increase those sores that don't heal. People with diabetes quite often have to go to a podiatrist to have their toenails trimmed, because if they cut themselves, maybe they trimmed their nail too deeply, caused it to bleed, and that doesn't heal, it could result in them losing a toe. And they surgically remove that toe, then that doesn't heal. And then that dead tissue spreads, you have necrosis of the tissue, then they lose half a foot. Then they have to amputate their whole foot. Then eventually they end up with a above knee amputation of their leg, and that could all start with trimming a toenail. Changes in vision, I've already described how that would happen. That same inflammatory process that restricts perfusion, that oxygenated blood isn't getting to the retina. Numbness in the feet, that would be diabetic neuropathy. That inflammation damages nerves. That inflammation and poor blood flow damages nerves and damages sensory nerves in the feet, and that causes numbness. Diabetic retinopathy is that change in vision. All right. Hyperglycemia, we've talked about most of it already. Okay, we've talked about diabetic ketoacidosis, type 1 diabetic, super high blood glucose levels. Remember, that could be 400 plus milligrams per deciliter of blood, and utilizing fat as an energy source, and then you have those ketones as a byproduct, and then having those ketones in the blood that causes acidosis, and the Kussmaul respirations, and you have somebody who they're dehydrated. We talked about how we find the dehydration, and then excessive urination, trying to flush these acids out, and that ketonuria, trying to flush that out, trying to and then they're spilling glucose because the filtration in their filtration system in their kidneys plugged up, and then they're spilling that sugar into their urine. So what do we see in a type 2 diabetic? We painted a good picture of type 1. Type 2 diabetics who are hyperglycemic, they have hyperglycemic hyperosmolar non-ketotic syndrome. And some books have hyperosmolar hyperglycemic non-ketotic syndrome. So what in the heck? So they have they're not digesting fat, so they don't have the ketones. They are dehydrated because of all the fluids that they're moving through, and they're hyperglycemic because they can't move. They're not moving sufficient amounts of glucose into the cells with the insulin that they have. And you can see with HHNS, you can see patients with 6, 7, 1200, 1800, 2000 blood glucose levels. Remember, 100 would be our upper limit to be in normal range. Okay. With HHNS, we're talking a type 2 diabetic, hyperglycemia, altered mental status, drowsiness, lethargic, I have no energy, they're drowsy, they just not thinking clearly, just don't respond appropriately when we ask them questions, severely dehydrated. They have, because of that, that polyuria, polydipsia, they're thirsty, they can't get enough liquids. And they have, normally when you drink a lot of liquids, not to give away any former secrets, but I have heard when somebody consumes massive quantities of beer when they're college age, that their urine becomes almost clear. And so think the opposite of that. The kidneys, you have all the, you have that ketonuria, you have all that glucose spilling into the urine, and you get really dark urine, and the kidneys aren't functioning well. So it's just that dark urine that goes with poor renal function, and then visual deficits, maybe that peripheral diabetic neuropathy. Their hands don't work right, their feet don't work right because those sensory muscles are compromised. Possibly they're dying and they're just totally losing feeling, or they just have numbness. And when you have diabetic neuropathy in your feet, you don't get good feedback when you walk, so you may be more prone to falls. Then you fall and you injure yourself, then you have a wound that doesn't heal. It's very important to try to maintain those sugars in range. Okay, and then even seizures. Hypoxic brain will cause a patient to have a seizure. A hypoglycemic brain can cause a patient to have a seizure. Okay. Hypoglycemia, we keep bouncing back and forth, right? Hypoglycemia, not going to have the glucose required to provide energy to the cells. Brain cells that don't have sufficient glucose result in altered mental status or even being unconscious, unresponsive. How does this happen? You could have an insulin-dependent type 1 diabetic, and they maybe, let's make up a crazy scenario. Maybe Susie always injects her insulin right after she finishes doing her hair, puts her makeup on. I don't know which order that normally comes in, but normally injects insulin. Then maybe her husband's already taken the kids to school, and she injects her insulin because after she gets ready to go to work, she always goes in and eats. She's injected the insulin. She gets a call that one of her kids has fallen at school and hit her head and is unconscious. So she forgets to eat breakfast. She jumps in the vehicle and she heads to the school. That insulin is working away, moving that glucose into the cells until what? Start running out of glucose to move into the cells. And then that start to see the development of altered mental status. And maybe she's driving. She becomes mentally impaired while she's driving because she doesn't have glucose to feed her brain. She runs off the road and hits a telephone pole. Now you have a hypoglycemic patient who has possibly blunt force trauma, who also has a kid who has blunt force trauma to the head. So we got all kinds of problems going on here. Medical conditions and trauma aren't mutually exclusive. They can exist together. So always look for both. With altered mental status from hypoglycemia, some people just become confused and maybe have some bizarre behavior. Some become aggressive and combative. It differs from person to person. Keep them from hurting you until somebody can get some glucose in them, and then they will feel all better. That requires usually, if they have altered mental status, can't give it to them orally. We're going to have to call for a paramedic, or we're going to have to rapid transport them to the emergency department so that an IV can be started and IV glucose can be administered. If they're hypoglycemic long enough, permanent brain damage will ensue and eventually death. Okay. We're doing well, believe it or not. Hypoglycemia, it develops, it's a quickly developing thing. Usually, we're talking minutes. Hyperglycemia, that can take hours and days to develop. Hypoglycemia, signs and symptoms. What do we see? Normal to shallow rapid respirations, pale and diaphoretic, dizziness, headache, tachycardic. Blood pressure is usually low, usually normal to slightly low. Altered mental status, could be anxious, could be combative, could just be confused, could be unconscious, unresponsive, could be having a seizure. Patients with seizures, we talked about seizures and syncopal episodes and comas last week. Remember, with your patients who present with a neurologic emergency, if your protocol allows, go ahead and get a BGL. If it doesn't and you have a glucometer, contact online medical control and get an order to get a BGL. If you don't have a glucometer, you either need to call for a paramedic unit, an advanced life support unit to come get a BGL, treat the patient accordingly, or it may just be supportive care and rapid transport so that they can manage it at the hospital. Could present with stroke-like symptoms. Good sample history and a BGL will help distinguish the signs and symptoms of hypoglycemia from a stroke. You see rapid changes in mental status. They go from conscious alert talking to you to unconscious unresponsive very quickly. Scene safety, remember that often diabetics use syringes to inject insulin. Don't inject yourself with a contaminated needle. Be careful. Watch for those suckers. Watch where you put your knee down to kneel. Watch where you put your hand down to get up. Watch where you put your hand in the bed beside an unconscious, unresponsive diabetic patient. Standard precautions, protect yourself from blood and body fluids, right? We know how to do that. We may be getting a sample history and OPQRST related to your patient's presentation from bystanders, co-workers, friends, family, or we may not be able to get it at all. Remember to assess for any trauma that may have resulted due to the nature of your patient's illness. They can have MOI and NOI both going on. General impression, sick, not sick, critical, not critical. Airway and breathing, we're going to provide high flow oxygen or possibly even positive pressure ventilations to patients with an SpO2 of 94 or below. Patients with Kussmaul breathing, they may have a sweet, fruity odor on their breath. Some mistake that for booze on the breath. They don't smell the same to me, but some people think they do. Maybe they just haven't smelled it enough. I don't know. Not everybody in this world has smelled ketones on somebody's breath who's having Kussmaul respirations. Oh, nope, there's something magic happening. Yeah, this is from a long time ago when I was amusing myself with animations and PowerPoints. Manage respiratory distress, manage respiratory failure. Prompt transport, we already talked about that. If your patient's capable of swallowing and following instructions, they're hypoglycemic, but they don't have sufficiently altered mental status, we can give them oral glucose. If they have altered mental status, we cannot give them oral glucose. We need to call for ALS to pop in an IV and handle that with an injection of glucose. So we're going to ask these diabetic patients, when was their last meal? How much did they eat? Have they taken their insulin? Did they take the normal amount of insulin? When was the last time you ate? Have you taken your oral anti-hyperglycemic medication? What is that? Type 2 diabetes. That's that oral medication that helps move move insulin and glucose into the cells. Okay, we already talked about those. An unresponsive patient needs to be assessed from head to toe to look for any potential trauma. My preference, and I added this because this is my preference, even though it's not a trauma strip head to toe physical examination, every patient needs to have a head to toe physical examination. It may not be trauma strip, get naked and see what's going on and palpate what's wrong, but assessing them head to toe, it's good medicine. Get their socks and shoes off so you can assess their pedal pulses. You can look to see if they have dry, flaky skin on their feet. They have poor skin turgor on their legs. It's important to be able to have sores on their feet that aren't healed. And you can push their pants up, most people up to pretty much up to their knees, and you could look for any signs of poor circulation in their legs, any wounds that don't heal. Okay. Talked about glucometers, talked about those. Non-fasting BGL, so that means they're still eating. A fasting BGL, usually they cut off your food at midnight and can't have anything to drink but water, and then first thing the next morning you get up and you go in and they draw some blood to get a fasting blood sugar. We're talking non-fasting, eating and drinking normally, 80 to 120 in adults and children. Neonates should be above 70. Things are, we'll talk about this when we do childbirth and neonatal assessment, but baby's body is trying to adjust to the change from fetal circulation with mom's help with everything to independent circulation, and so things take a while to get ironed out. Reassess 5 minutes or 15 minutes, right? Or change in your patient's condition. Administer glucose if they can swallow, and if your protocol allows, or you may have to contact medical control to get permission to administer either instant glucose, that gel stuff that's administered via the buccal route, right there between the cheek and gum, or they may have glucose tablets that you can do patient-assisted administration of that. If their mental status is altered at all, nothing by mouth. We need rapid transport and ALS. Why? Because the risk of aspiration. Patient who has altered mental status cannot protect their airways, so we don't need to be giving them anything by mouth. If you're not allowed to assess blood glucose level, or say your glucometer just doesn't work, it just malfunctioned, it's a piece of crap, it won't work, perform a thorough assessment, rapid transport, contact the hospital to help sort out signs and symptoms, call for ALS, communicate all your findings to the receiving hospital, including your interventions and the results. So if we administer glucose, we're going to assess our patient prior to the administration. Then we're going to administer the glucose, then we're going to reassess, right? If your patient refuses transport, which happens often, they just took their insulin, they didn't eat, we come in. This particularly happens in the ALS world when we're given IV glucose. Patient responds, they're now conscious, alert, well-oriented, they're in good shape. They refuse transport. We need to thoroughly document everything with them, or we assisted them with some glucose paste or some glucose tablets. They're better and they don't want to go to the hospital now. We need to document really well our assessment, the patient's presentation, our assessment of that patient, and any treatment we provided in their response to that treatment. That's what glucose gel looks like. That one has 15 grams of glucose in it. Wear gloves before you put anything in a patient's mouth. Again, you have to protect yourself. Reassess frequently, provide transport, contraindications for oral glucose, inability to swallow, unconsciousness. Follow your local protocol for any glucose administration, as well as ascertaining a BGL. Seizure, obviously, we're going to consider that to be serious, right? Call for ALS, manage their airway, provide positive pressure ventilations if indicated. What could be causes of that seizure? Infection, poisoning, hypoglycemia, trauma, decreased O2 level, idiopathic. That means we don't know what the heck caused it. In medicine, we needed a cool sounding word instead of saying, I don't know. So that's idiopathic. Idio, unknown, pathic, unknown pathology. And fever, undiagnosed epilepsy. Make sure the airway's clear. Position them on their side so they don't vomit and aspirate. Nothing in the patient's mouth. Have suction ready. Provide oxygen with BVM if they have inadequate breathing or cyanosis. Transport promptly. Call for ALS to meet you on the way. Remember an altered mental status. It's not always glucose. It's not always hypoglycemia. We have an acronym to help us. We talked about it last week. AEIOU tips. Learn that. Alcohol, epilepsy, insulin. They take their insulin and not eating. Overdose. We need to rule out drug overdoses causing this altered mental status. Underdosing of insulin could eventually cause altered mental status. It takes a while. Trauma, infection, maybe your patient has altered mental status because of meningitis. Maybe they have cerebral abscess. Pus in the brain just kind of gives you a chill up your spine, doesn't it? Psychosis, it could not be, maybe there's not a physiologic component. Maybe it's a psychological component that's causing altered mental status, and then possibly a stroke. Remember, if it's possible stroke, last time they were known to be normal. Talked about, that was on the exam today, right? I hadn't looked at it. Hopefully everybody got that right. I kind of hammered that the other day. Make sure their airway is clear, provide positive pressure ventilation. If needed, remember that we suction prior to that. We don't want to blow vomit down into their alveoli. That's just poor form. That's not what a good clinician does. Prompt transport. Sometimes hypoglycemia is mistaken for a neurologic issue. Sometimes it's mistaken for intoxication. Not as much as it used to be, because I think we do a good job of educating law enforcement now. That used to be the big risk, and it was law enforcement to misdiagnose, just determine that the subject is intoxicated when they actually are having a diabetic emergency. Remember, altered mental status. It may have a poor gag reflex. GCS of less than 8 is going to have a poor gag reflex. Tell you what, if you need to go now, I'm into your time. I will finish out hematology here, and I will, as soon as I can get this long file converted to MP4, I'll get that up on my YouTube channel, so I'll keep on trucking here. Hematology, study of blood-related diseases. Ones we'll talk about here: sickle cell disease, hemophilia, and thrombophilia or thrombocytopenia. You know the components of blood. You know what blood does. Red blood cells carry oxygen. White blood cells are connected to our immune system. They are the warriors that go out there and fight infection for us. Platelets, remember, those are those building blocks that form clots. And last week we talked about that clot formation, that clotting cascade in ruptured plaque in a coronary artery, and that those platelet aggregation leads to eventually to an occluded coronary artery, which causes myocardial ischemia and the death of myocardial cells, which is not a good thing. And last week we were having our patients chew and swallow 324 milligrams of baby aspirin to help interfere with that platelet aggregation. So it could be that our patients have poor platelet aggregation. They're missing a clotting factor, so if they get cut, they just bleed out because that clotting cascade gets short-circuited. Plasma, that's the vehicle that drives all this around. That's that straw-colored liquid stuff that if you spin blood down in a centrifuge, it separates out into plasma, white blood cells, red blood cells. Sickle cell disease, it affects red blood cells. Where'd it go? It causes this sickle-like morphology or shape, the sickle-like morphology of red blood cells. That would be a normal red blood cell. This bad boy right here does not carry oxygen as well as this normal shape that has the four hemoglobin molecules, that the oxygen molecules the four hemoglobin molecules that carry the oxygen molecules around to the tissues of the body. This misshapen sucker just is not good at carrying oxygen. Who is prone to sickle cell disease? People of African descent, so African Americans, very dark-skinned people, people of Caribbean, South American, and Mediterranean ancestry are at risk for sickle cell disease. For the last, I bet, 40 years or more, maybe pushing 50 years, newborn babies, neonates who are of an ethnicity that they're at risk for sickle cell disease will have sickle cell testing done early in life to screen for sickle cell disease, so that sickle cell disease can be managed. The other problem that's caused by those sickle-shaped cells, it triggers unintentional, unnecessary clotting, which can be horribly painful and cause some serious conditions in our patients. Clots can also call it a vaso-occlusive crisis. Those sickle cell, those misshapen red blood cells kind of stack up and they block circulation. Can lead to hypoxia, pain, organ damage. Sickle cells have a shorter than normal lifespan, so you have more of the waste products trucking around in the blood, and it kind of sludges up and it interferes with circulation. What kind of complications? Anemia. Anemia is low red blood cell count. Gallstones. There's a higher risk of gallstones. Remember, the bile comes from old, dead, worn out red blood cells. And if you have a shorter than normal lifespan of red blood cells, there may be maybe an overproduction of bile, and that may lead to the development of gallstones. If hepatic function, if liver function, if hepatic function is impacted, your patient will present with that yellowish skin color. Jaundice is what we call that. They may present with icteric sclera. What in the world, buddy? You just threw something new at me. Icteric means yellowish. That's the Texan translation, by the way. Sclera, the white of the eye. So patients with poor liver function, their bilirubin level is higher, and that causes that yellow skin color, which can also show up in the sclera with that yellowish color. So that's in your patients with very dark pigmented skin. You may have difficulty seeing the jaundice. You may think it's there. I'm not sure it's there. Is it there? If they also present with icteric sclera, that yellowish white of their eye, then that's going to tell you that something is impacting that liver function. And then the spleen, it's a filter, and all those short-lived red blood cells can cause the spleen to dysfunction, and that causes left upper quadrant pain that can impact the immune system. So it can be an overwhelming thing for patients. Has to be managed with blood transfusions, as far as I know. Vascular occlusion with ischemia. What does that cause? Acute chest syndrome. That triggers chest pain, and it may, those big clumps of red blood cells, dead red blood cells, misshapen red blood cells, that can cause a stroke. It can cause joint necrosis, so they can have failure of joints because the tissues are poorly perfused. They can just hurt all over, just horrendous pain. It's a pain probably almost like no other. Okay, retinal hemorrhages, heightened risk of infection. That's the morphology. We can't diagnose that pre-hospitally. We can't see that, so we're going off of patient history and presentation. Another hematologic disorder, hemophilia. That is, the patient is missing a clotting factor. One of the common ones is factor 8. Factor 8 is part of that clotting cascade. When bleeding starts and that clotting cascade kicks in, there are clotting factors, and factor 8 genetically is often the missing clotting factor. Hemophilia, mostly going to see in males. Females are carriers. It makes sense. Just commonsensically, if you have a female who is a hemophiliac, when menstruation starts, when you have menarche and they start shedding that lining of the uterus roughly every 21 days, roughly every 28 days. It's a 28-day cycle. So roughly every 21 days, they start shedding that lining of the uterus and they start bleeding. If females were hemophiliacs, there would be hemorrhage rather than bleeding. Okay, how's it treated? Infusions of factor 8. That's not done by EMTs or paramedics unless that paramedic's working in a clinic, in a definitive care type setting, which paramedics can do now. The scope of practice extends into ERs and hospitals. Big risk would be hemorrhagic stroke, intracerebral hemorrhage, thrombosis due to treatment. What's that mean? That means a blood clot that lodges somewhere it's not supposed to. Do we have a pulmonary embolism? Is it a stroke due to a thrombus, a blood clot making its way to the brain? All depends on what's happening in your patient. Again, we're not going to be able to determine that pre-hospitally. Thrombophilia, they just don't maintain smooth blood flow through the venous or arterial systems. Just know it exists. We're not going to figure this out pre-hospitally. Maybe our patient tells us they have a history of it, then that makes sense. What happens? Blood clots more easily than normal. It's a genetic disorder, or it could be triggered by medications, could be triggered by an infusion of clotting factors, maybe too great of an infusion of clotting factors, and then patients with cancer just spontaneously develop clots and they start throwing those clots. So you can see them in the lungs, pulmonary embolism. You can see ischemic stroke from those from those clots occluding cerebral vessels. And then DVTs, that's deep vein thrombosis, happens in sedentary patients and patients who have had a recent injury. Think about maybe you have a patient who has recently had surgery and they're not ambulating well. Maybe they refuse to ambulate, just want to stay in bed, and eventually they may form a clot in the leg. Leg would be a very common location for a DVT, and then they throw that clot, and then they either have a PE or a stroke. Pulmonary embolism would be an occlusion. That clot occludes one or more of the pulmonary arteries. So if you have a patient with rapid on. They've had a recent surgery, or they've been on a long trip. They have pain in their leg, usually just one leg. They have pain in a leg, and they have a sudden onset of shortness of breath with severe chest pain. It may be cardiac, but it also may be a DVT. How is it? How are DVTs treated? Blood thinners, compression stockings, may even have a surgically implanted filter that filters out those clots to keep them from making their way into central circulation. So risk factors, recent joint replacement, and they complain of leg swelling, travelers long distance, truck drivers, bus drivers, long intercontinental flights, somebody who has a predisposition to DVTs, they could maybe just take a coast to coast nonstop 3-hour flight, and whatever it takes, I'm not sure what it takes, 3 or 4 hours, and they don't get up and move around, so that, and circulation is impaired, they could develop a DVT and then either throw a PE or have a stroke, and then bedridden nursing home patients. After diagnosis with the DVT, you can plan on treatment with anticoagulation medications for at least 3 months, possibly 6 months, a year. Just depends on what medication and how extensive the DVTs are and how well they respond, the patient responds to the medication. Patients who are being treated for DVTs, maybe they're taking Coumadin, maybe they're getting get blood thinner injections, we'll call it that. They can have a high risk of bleeding complications. Almost done. So what if our patient has a pulmonary embolism from a DVT? They have chest pain, shortness of breath, they're tachypnic, they may even have sudden cardiac arrest. That is an absolute giddy up and go emergency supportive care in our world. And then if they go into cardiac arrest, of course, CPR, be ready to assist their ventilations. The pulmonary arteries that aren't occluded by emboli, you need to provide a maximum amount of oxygen possible down in the capillary beds and the alveoli, so that we can maximize oxygenation. Positive pressure ventilation is definitely indicated. Consider ALS. Remember to always wear your PPE. Here's some physical signs of sickle cell crisis: swelling of the fingers and toes, priapism, that's an erection that does not go away, jaundice, severe pain, those can be signs of a sickle cell crisis. Get a history from the patient, family, maybe bystanders. I don't know if bystanders are necessarily going to be much help there. Is the pain in a single location or throughout the body? Is there swelling in a single location throughout the body? Do they have visual disturbances, nausea, vomiting, abdominal cramping, shortness of breath, chest pain? This does not sound like fun. Has this ever happened before? If you have a patient with sickle cell disorder, it's likely if we respond to their sickle cell crisis, they have had it How was your last one treated? How long did it take for it to resolve? Have you been sick recently? And that covers the chapter. All right. Thanks for hanging around a little extra time. For those of you who couldn't, I will get this posted for you.